Bismillahirrahmanirrahim. Today, discussing the disorders of the stomach, we will discuss chronic gastritis. Before going to discuss the chronic gastritis, it is important to say that gastritis, by which we mean inflammation of the lung, inflammation of the gastric mucosa, it may be acute and chronic. In our last lecture, we discussed acute gastritis, and here I want to mention that acute gastritis, acute gastric ulceration, chronic gastritis, and peptic ulcer, and even adenocarcinoma, all these are interrelated conditions. And in most of these disorders, one disorder evolves into another. For example, if we recall the inflammation, the acute inflammation, when it is not resolved, either because of the severity of the invading agent or because of some defects in the underlying mechanisms, it will evolve into chronic inflammation. So similarly, the acute gastritis that can lead to complications like gastric ulceration, gastric perforation associated with bleeding, hematemesis. Repeated attacks of acute gastritis can lead to chronic gastritis. And in some instances, chronic gastritis may be of chronic origin from the start. Gastritis, by which we mean inflammation of the gastric mucosa, it is divided into acute gastritis and chronic gastritis. In acute gastritis, the symptoms are severe, while in chronic gastritis, comparatively, the symptoms and signs are not so prominent. Acute gastritis in its severe form can evolve into acute gastric ulceration. And acute gastric ulceration has its own complications like perforation of the stomach, for example, severe bleeding if a blood vessel is involved. On the other hand, the chronic gastritis, the two major types of chronic gastritis are the one induced by the gram-negative bacillus, the bacterium Helicobacter pylori, known as the H.pylori gastritis, and the other types is the autoimmune gastritis, which results from an autoimmune reaction of our immune system against our body own tissues. And in this condition, the own tissue that give rise to the development of the antibodies are the axanthic or parietal cells in the stomach. By that I mean that antibodies are produced against the parietal cells of the stomach, which are located mainly in the fundus and corpus or body of the stomach. And the function of those parietal cells, also known as the axanthic cells, is to produce HCl, hydrochloric acid, as well as the intrinsic factor, which is important for the ileal absorption of vitamin B12. And we know that vitamin B12 is essential for the synthesis of red blood cells. So here the H.pylori gastritis, which is caused by the gram-negative cowed bacillus known as the Helicobacter pylori, it can evolve in its severe form into peptic ulcer. And this type of gastritis giving rise to the peptic ulcer, it is associated with excess production of the hydrochloric acid. Here it is important to mention that the same peptic ulcer can be produced by drugs known as the non-steroidal anti-inflammatory drugs. The autoimmune gastritis, which leads to destruction and atrophy of the parietal or axanthic cells, they will lead to very little or no production of HCl from the axanthic cells, as well as lack of intrinsic factor. So when there is very little acid production, the condition will be called achlorhydria, no acid. While the lack of intrinsic factor, which is important for the absorption of vitamin B12, and when there is no intrinsic factor, there will be no vitamin B12 absorption and defective formation of the red blood cells, leading to pernicious anemia, which is characterized by the large mega erythrocytes known as the megaloblasts. Now, as I mentioned that we divide the causes of the chronic gastritis, which is the chronic gastric mucosal inflammation, into three types. The most common type is the one that is caused by the Helicobacter pylori bacteria. Helicobacter pylori is a gram-negative bacillus, and it is the one of the spiral-shaped or curve-shaped bacilli, and the Helicobacter pylori gastritis is the most common form, 90%. Here I want to mention that not each and every person infected with Helicobacter pylori will develop chronic gastritis. It is said that half of the world population, when they are examined, they have H. pylori in their stomach. But not all will develop the gastritis and later on its complication in the form of peptic ulcers. So, after the most common cause, which is H. pylori, Helicobacter pylori infection, the second type of gastritis is autoimmune gastritis, which occurs in less than 10% of the causes of chronic gastritis. 90% causes are with H. pylori gastritis, and less than 10% are with autoimmune gastritis. It is also known as the atrophic gastritis. Compared to H. pylori, it is a less common condition, and the very rare causes of chronic gastritis in which there can be chronic inflammation in the gastric mucosa, these are radiation. If we are radiating the patient for some sort of cancer or other reason, we can damage the gastric parietal cells, chief cells, and other cells. While the chronic bile reflux, regurgitation of the bile containing contents from the duodenum into the stomach, it can also lead to chronic inflammation in the gastric tissue. Similarly, alcohol can also cause it, and tobacco and caffeine are also included in the causes. The most important cause is H. pylori, 90%. Less than 10% causes are autoimmune reaction, and very rare causes are radiation, chronic bile reflux, alcohol, tobacco, and caffeine. Here we must know three important points. When we compare chronic gastritis to acute gastritis, the symptoms are less severe, but they are persistent. In acute gastritis, the symptoms, though they are severe, but they go away after removal of the causating agent and treating the patient. But in chronic gastritis, mostly the symptoms, and which are less prominent and less severe, but they are persistent. In chronic gastritis, the increased acid secretion, which particularly occurs in H.pylori gastritis, may result in the formation of ulcers in the gastric mucosa, particularly at the region of the lesser curvature and in the first part of the duodenum. And this situation, or these ulcers produced by H. pylori gastritis, are known as the peptic ulcer disease. Chronic gastritis, H. pylori gastritis or autoimmune gastritis, they provide a substrate medium for cellular dysplasia. When the gastric mucosa becomes atrophic, what happens that in some situations intestinal metaplasia occurs. Intestinal mucosa comes to lie in the stomach, which is an abnormal site for it. And in intestinal metaplasia, the goblet cells, which are particular for the intestine, the goblet cells are the mucus secreting cells in the intestine, while in the stomach the mucus secreting cells are known as foveolar cells. The lining mucosa of the intestine, it is absorptive in nature. It absorbs things. If this intestinal type of mucosa with goblet cells, if it comes to lie in the stomach, we say this metaplasia. And once metaplasia occurs, then it goes into dysplasia, from mild to moderate, then into severe, and then anaplasia, and finally neoplasia and adenocarcinoma of the stomach. So the story for the cancer stomach formation starts from the metaplasia, and then it goes through the stages of reversible to irreversible stages, from the metaplasia, which is reversible, mild, moderate, severe dysplasia, and then into anaplasia, and finally neoplasia. So the chronic gastritis in any form, it provides a fertile soil for the development of the gastric carcinoma. Now, Helicobacter pylori gastritis. Helicobacter pylori is a bacterium. It is a gram-negative curved bacillus, and it is present in the stomach in half of the world population. And in most of the individuals, it doesn't cause any problem. And it may be considered as a commensal. What is a commensal? When it is living in the host, but it doesn't cause damage to the host. So there are Helicobacter pylori in the stomach. They are living there, but they are not causing any damage. But in certain individuals, the H. pylori bacillus has the potential to cause damage, leading to chronic inflammatory conditions in the stomach. And this chronic gastritis in its severe form can evolve into the disease peptic ulcer, in which gastritis uh, evolved into peptic ulcer. For example, gastric ulcer in the stomach, mostly in its lesser curvature, and duodenal ulcer in the first part of the duodenum near the pyloric sphincter. Now, how people are infected by H. pylori? Mostly, the oral fecal route is the most common route. The bacterium passes in the stools, and by any way, if this bacterium reaches to the mouth of the other person, he can become infected. Gastro-oral route. If the infected person vomits, and if he is having H. pylori in his vomitus, this can reach to the stomach of another healthy person. And oral routes is also a possibility. But once the H. pylori enters into the stomach, now in the stomach, this H. pylori is faced by a very harsh situation, because due to excess hydrochloric acid which is present inside the stomach, it is highly acidic. The pH is just near to 1 or 1.5, and we know that this is a very harsh medium. Now, this flagella is provided with this bacterium is provided with flagella, which act like feet of the bacterium. Now, in the stomach, this bacterium will try to run out of the most acidic site. Since the body and the fundus contains the parietal cell along with chief cells, and the parietal cell, they secrete HCl, so this is unfavorable site for the bacterium, so it will run towards the antrum of the stomach. The antrum of the stomach is the position which leads into the pyloric sphincter, and in that situation, the chief cells, the parietal cells secreting HCl, they are very less in number. So these bacteria run using their flagella in the thick mucus layer in the stomach to hide themselves in the area of the near the antrum of the stomach, where the acidic medium is comparatively less harsh. Now, once in the antrum, the bacteria will use the adhesion molecules, which is the second weapon after the flagella that is possessed by these bacteria. By using adhesion molecules, these H. pylori bacteria adhere themselves to the foveolar cells, mucus secreting cells, and establish themselves at that site. Now the bacteria will use its third weapon. It secretes the enzyme known as the urease. And urease will convert urea into ammonia. And ammonia is an alkali. It will increase the pH, making it alkaline. And in this way, the bacteria protects itself from the surrounding acidic environment. It has produced an alkaline pH around itself, and now it is comparatively safe from the acid. Now the bacteria has walked to antrum. It has adhered to mucosal foveolar cells. It has started to produce urease, and it has created an alkaline pH around itself, and now it will start its weapons to damage the gastric mucosa. And this weapon, this is the toxins. Two types of toxins are very important. One is the cytotoxin associated gene A, which is known as the cake A, and the other is the exotoxin vacuolating cytotoxin A, जिसको हम wake A कहते हैं. And we will not go into the very minute details of these toxins, but using these toxins, these bacteria, they damage the epithelial cells. The epithelial cells that line the surface of the gastric mucosa, they are damaged. And when by using these toxins, these bacteria kill those surface covering epithelial cells, what will happen that the underlying mucosa is exposed to hydrochloric acid. And now further pathology will be induced by the hydrochloric acid. The toxin produced by the H. pylori cause epithelial cell death. And as more and more epithelial cells die, holes are produced in the mucosal lining, and they are called the ulcers. Ulcers are holes when the overlying mucosa becomes dead, automatically excavating the gastric mucosa and producing ulcers. If it is in the stomach, particularly in the lesser curvature, it will produce gastric ulcer, and if it is in the duodenum, which is in the first part of the duodenum closer to the pyloric sphincter, it will be duodenal ulcer. Moreover, the inflammation induced by the HCl damaging the gastric mucosa, it will also stimulate the G cells. We have studied in our previous lecture the protective mechanisms that the G cells are gastrin secreting cells which are mostly located in the gastric antrum, the region where the stomach continues into the pyloric sphincter. And the G cells which are produced normally in response to the presence of food in the stomach, they are carried in the blood and they will stimulate the parietal cells to produce more and more HCl. So this is the other problem associated with the inflammation induced by the HCl, that the inflammation stimulate gastrin stimulating cells to stimulate the parietal cells to produce HCl. Here I want to mention that the G cells, they are also present in the small intestine and also in the pancreas, and they can give rise to a condition where a tumor is formed known as gastrinoma, and the situation and the condition that result from that particular tumor is known as the Zollinger-Ellison syndrome. Now, the ulcers are formed, but now if these ulcers become deep more and more, there is the possibility that they may erode the underlying blood vessels. And the ulcer will go starting from the mucosa, submucosa, muscular layer, serosa, and even it can cross the whole thickness of the stomach or duodenum. And in this situation, what will happen? The stomach or duodenum will get perforated. And this is a type of surgical emergency, because if a perforation occurs in the intestine, small intestine or duodenum, or in the stomach, the contents present there, they will leak into the peritoneum. And this can be a catastrophic condition and if not treated with emergency surgical basis, it can lead to severe shock and the patient can die. Now, in some situations, in when the disease is not so severe, but if the duodenal ulcer, if it is present for longer periods, what will happen? That we know that the difference between acute and chronic inflammation is that one of the differences between acute and chronic inflammation is that in chronic inflammation, an element of healing, fibrosis, or scar tissue formation is added. That is absent in acute inflammation. Since this is a chronic inflammation, so the element of healing and scarring can occur in it. And sometimes there is so severe fibrous tissue formation and so severe scarring, particularly at the pyloric sphincter, that it becomes narrow and the passage of gastric contents from the stomach into the duodenum, it becomes obstructed. And the patient will have a gradual onset of nauseated feeling and vomiting. As I have said, that H.pylori gastritis as well as autoimmune gastritis, both of them are risk factors for adenocarcinoma, cancer of the stomach. Now it becomes clear that so many people are infected with H. pylori, but only a small portion of all these H. pylori infected people will develop chronic gastritis. And out of the chronic gastritis, some of them will develop peptic ulcer. And by inducing high acid secretion in H. pylori, chronic H. pylori gastritis, what can happen that the infection can cause grooves and holes in the stomach, which is particularly at the level of the lesser curvature and in the first part of the duodenum, leading to peptic ulcer, gastric ulcer, or duodenal ulcer. And again, by inducing atropic changes and metaplasia, H. pylori can lead to the development of and is considered a stronger risk for adenocarcinoma of the stomach. Now, morphologically, what we will see, what we are going to see. So, in an acute episode, we may see that the mucosa is inflamed and erythematous due to high vascularity with exudate due to increased vascular permeability. Now, in this situation, we can see the organisms present in the overlying mucous epithelium, the mucus which is secreted by the foveolar cells. Neutrophils are the hallmark of acute inflammation, and they are present in acute episodes inside the epithelial cells. And the pits, gastric pits, where the gastric glands are located, they can form pit abscesses there. So in this lesion, we can see acute inflammation. Moreover, deep to acute inflammation, there can be infiltration of the chronic inflammatory cells, plasma cells, lymphocytes, and monocyte macrophages. So here, in this picture, we see acute inflammation, chronic inflammation, and even more at the base of the ulcer, we may see fibrous tissue, proliferation of the fibroblasts, and scar tissue formation. So here the situation of 3 in 1 happens. We can see acute inflammation, chronic inflammation, and even the healing process. In long-standing chronic gastritis, what happens that the mucosal cells, foveolar cells, they becomes atrophic. And what happens that the lymphoid tissue, which is situated in the submucosa, it will proliferate and sometimes forming typical germinal centers as that we see in the lymph nodes. And this lymphoid tissue, known as the mucosa associated lymphoid tissue, can lead later on to another tumor known as the malt lymphoma, mucosa associated lymphoid tissue lymphoma. In some cases, particularly when there is atrophy of the mucosal cells, intestinal metaplasia occur. Metaplasia, which is a reversible adaptation, is the one in which one adult type of epithelium is replaced by another adult type. Here, the mucus secreting cells in the stomach are the foveolar cells, while the mucus secreting glassed or flask-shaped cells in the intestine, they are known as the goblet cells. The mucosa of the stomach is not absorptive mucosa, while the mucosa of the duodenum and small intestine, it is absorptive mucosa, which contains the columnar absorptive cells. So what happens in intestinal metaplasia, that in the stomach the intestinal type of mucosa comes to lie. Normally there is very little absorption in the stomach and the mucus secreting cells are foveolar cells, but now after metaplasia we will be able to see the goblet cells, which are normally present in the intestine. They are also mucus secreting cells, and we will see the columnar absorptive cells. And once metaplasia has occurred, it is a red signal that it may evolve into dysplasia, anaplasia, neoplasia, and overt adenocarcinoma in the stomach. These are the pictures. You can see the top left picture, which shows flagellated motile H.pylori organisms in the mucous membrane. In the top right, you can see the polymicronuclear leukocytes and infiltration of the neutrophils is mostly seen in the superficial mucosal epithelial layers, and in the lower left we can see the large number of lymphocytes which infiltrate in the submucosa particularly, and also we can see the plasma cells. So here there is infiltration of the chronic inflammatory cells, lymphocytes, plasma cells, monocytes, macrophages, and lymphoid aggregates. In the lower right picture, we see intestinal metaplasia, and we can see the goblet cells and intestinal absorptive cells in the stomach, and they should normally be present in the intestine, not in the stomach. But if the intestinal absorptive cells and if the goblet cells, they comes to lie in the stomach mucosa, this is known as the intestinal type of metaplasia, and it carries high risk of undergoing dysplasia and anaplasia and adenocarcinoma. So presence of the bacteria in the mucous lining, acute inflammation, infiltration with neutrophils, chronic inflammation, aggregation of lymphocytes, plasma cells, monocytes, macrophages. Uh, they are characteristics of the chronic inflammation, and metaplasia. Signs and symptoms of chronic gastritis and H.pylori gastritis are the heartburn, shortness of breath, loss of appetite with or without weight loss. Now, here one thing that I want to mention, and that is very important clinically, that the pain in the epigastric region, it will become severe when the gastritis lies in the lesser curvature and in the stomach. And the duodenal ulcers, it will be relieved after taking food. But in gastric ulcer, the pain is very severe after taking food. Therefore, the patients of gastric ulcer, they refuse to eat food, and with over time they lose weight. While the persons with duodenal ulcers, since their pain is relieved after taking the food, so they gain weight. If the blood vessels comes into the erosion, what will happen? There can be severe bleeding. The blood may be vomited, or it may be passed in stool and give rise to melena. And if a nearby artery, like inferior gastric artery and gastroduodenal artery, if they comes on the way of the ulcer or erosion, severe bleeding can occur, and it can lead to hemorrhagic shock. If unfortunately perforation occurs when the erosion cross the transmural or the whole thickness of the stomach or duodenum, then what can happen? Air can collect under the diaphragm, and the diaphragm is supplied by the phrenic nerve. Severe hiccup may occur, and also here now there will be reference to the shoulder of the patient. The patient may complain of pain referred to his or her shoulder. Chronic infection with H. pylori, the iron that we take is normally used in our body, particularly for the formation of red blood cells. But here our enemy is lying in our stomach, and it will consume iron before we use it and we get it. So the H. pylori present, they will consume the dietary iron, and the poor patient, he will suffer from iron deficiency anemia. How we diagnose it? The most important test is presence of the antigen in the stool. The other serum or blood test is the antibody serologic test, which may remain even positive after the patient has been treated, and which is not a very reliable test. We can use the urea breath test, which is very important. We give urea to the patient, and we know that the H. pylori produces the enzyme urease. And by using the enzyme urease, it will convert urea into ammonia and carbon dioxide. And we can test carbon dioxide. Very specified machines are available, and this is a very common non-invasive test, and it is very sensitive. Bacterial culture is the confirmatory test. When through an endoscope we visualize the lesion, and we take collection, and we collect some specimen from, particularly from the pyloric antrum near the pyloric sphincter, and we can use the specimen to see histological under the microscope its morphology, and by that I mean direct bacterial visualization, and we can make a culture of it also to grow bacteria in the culture. In some cases, the polymerase chain reaction is used to give an amplification of the DNA of the bacteria. PCR test. Now, this is endoscopic view of the stomach, and here this is the normal person, and here we can see the H.pylori induced gastritis. Now coming to the autoimmune gastritis, is we know that an autoimmune reaction occurs against the parietal cells. You know that the gastric mucosa contains sheep cells, foveolar cells, parietal cells, G cells, enterochromaffin cells. So there are many cell types, but the most important three types are the foveolar cell secreting mucus, the sheep cell secreting pepsinogen, which is later on converted into pepsin, a proteolytic enzyme, and the parietal cells, it secretes hydrochloric acid, HCl, and as well as intrinsic factor. When there is no HCl, as a reaction, the gastrin secreting G cells will be stimulated, they will become hyperplastic, and they will cause excess secretion of the gastrin, which is a strong positive stimulator of the parietal cells for the HCl secretions. So we will get the condition of hypergastrinemia. When there is lack of intrinsic factor, which is also produced by the parietal cells, the vitamin B bara or vitamin B12, which is normally absorbed through the ileum, there will be no absorption, defective formation of the red blood cells, and large size megaloblastic anemia, large size megaloblasts can be seen, and the resulting condition is known as the pernicious anemia. In autoimmune gastritis, for making the diagnosis, we can see for antibodies in the serum and gastric secretions against the parietal cells and intrinsic factor. Sometimes the autoimmune reaction not only destroys the parietal cells that are associated with HCl secretion, acidic secretion, but they also destroy the sheep cells that secrete pepsinogen. Not so much as parietal cells, but if a considerable amount of sheep cells are also destroyed, we will get the decreased serum pepsinogen 1 level. As I said, there will be a reactionary G cell hyperplasia and excess secretion of gastrin and hypergastrinemia. Intrinsic factor, defective absorption of B12 or no absorption, megaloblastic anemia or pernicious anemia. Destroyed parietal cells, no acid secretion, and achlorhydria. And sometimes in long-lasting and severe autoimmune gastritis, the parietal and sheep cells are lost, and the mucosa become atrophic, and this type of mucosa is very susceptible to metaplasia, and here intestinal type of metaplasia occurs when the intestinal tissue comes to lie in the stomach. Goblet cells instead of foveolar cells, and absorptive mucosa instead of the normal non-absorptive mucosa of the stomach. Now this intestinal metaplasia is a threat that it will undergo dysplasia, and with the accumulating genetic mutations with abnormal ongoing cellular divisions, so much genetic mutations may accumulate that the gastric adenocarcinoma may occur. Now, coming to the summary, the two major types of chronic gastritis is pylori gastritis and autoimmune gastritis. H. pylori gastritis typically occurs in the antrum region of the stomach. The bacteria run away to this region because it contains less parietal cells, and since the parietal cells secrete HCl, so this is comparatively a safe site for the bacteria. And as the toxins secreted by the H. pylori destroy the surface lining epithelial cells, the underlying mucosa is exposed to HCl and a type of inflammation starts known as the H. pylori gastritis. The lymphoid tissue which is normally present known as the mucosa associated lymphoid tissue. Mucosa associated lymphoid tissue. Proliferation can occur in this tissue and it can lead to another type of cancer known as the lymphoma. On the other hand, autoimmune gastritis destroys the axanthic cells and there is decreased acid secretion, G cell hyperplasia secreting excess gastrin, achlorhydria less acidic secretions, pernicious anemia or vitamin B12 deficiency, and in the laboratory we get anti-parietal cells and anti-intrinsic factors, antibodies. Intestinal metaplasia can occur in both forms of the chronic gastritis and is a risk factor for adenocarcinoma. Now here we can see the difference between the H. pylori gastritis and autoimmune gastritis. The common site for H. pylori gastritis is the antrum, while the common site for autoimmune gastritis is the body. The antrum, the body contains chief cells, parietal cells, and the foveolar cells, while H. pylori affects the antrum which contains comparatively little number of the parietal cells. So this area or this region is comparatively safe for H. pylori. In H. pylori gastritis we can have neutrophils, but mostly in autoimmune gastritis the infiltration of chronic inflammatory cells occur. Do chronic inflammatory cells also occur in the H. pylori gastritis, but here we can have neutrophils and here mostly we do not have the neutrophils. In H. pylori gastritis, the inflammation induced by the HCl will cause increased acid production initially, while in a very late stages when there is destruction and atrophy of the parietal cells, then the acid secretion may be decreased, but initially here the hyperchlorhydria, increased secretion of the HCl, it is seen, while in autoimmune gastritis the axanthic or parietal cells are destroyed and there is achlorhydria, decreased secretion of the HCl. Gastrin, in autoimmune gastritis they are increased because lesser production of the acid by the axanthic or parietal cell will stimulate the G cells and there will be hypertrophy of the G cells and excess gastrin will be produced leading to hypergastrinemia. But in H. pylori gastritis such type of stimulation is not present and the hyperchlorhydria or the excess amount of acid secretion is not related to the gastrin. It is purely caused by the inflammation induced by the HCl. Serologically, we can see antibodies to H. pylori while the simple and more accurate test can be the presence of antigen in the feces and doing endoscopy and culturing the organisms for confirmation and histopathological examination of the lesion. While in autoimmune gastritis, antibodies to parietal cells and intrinsic factors can be seen in the gastric secretions and also in the serum, and endoscopy and biopsy may be done in when it is appropriate for the uh, doctor to do it and to think it is necessary. Here we will get the atrophic mucosa, and whenever we see the when we visualize the gastric mucosa, the presence of metaplasia, intestinal metaplasia, dysplasia, mild, moderate, severe, anaplasia, or even the presence of cancerous cells, it should be confirmed so that we come to know at an early time if such a complication is present here. The H. pylori gastritis will lead to peptic ulcer, adenocarcinoma, lymphoma, while autoimmune gastritis will lead to atrophy of the gastric mucosa, particularly the parietal cells, pernicious anemia, and both of the chronic gastritis types, they provide a risk for the development of the adenocarcinoma. Whenever we see one autoimmune disease in a person, we must look for other autoimmune diseases also. Therefore, a person with autoimmune gastritis may be searched for other autoimmune diseases like diabetes, thyroiditis, and other autoimmune diseases like Sjogren syndrome, Crohn disease, and the H. pylori gastritis particularly occurs in people where they live in overcrowding, poverty, and easily spread the infection from infected to healthy individuals. Thank you very much.